Welcome to Rumor versus Truth. This is the bonus mailbag episode where we answer one listener question outside of our regular full episodes.
And we're dropping this as a separate bonus so our main episodes stay focused and clean. And keep in mind, there's no seat available for this episode.
So this one's about laxatives that came in from a pharmacist through our Rumor versus Truth at trchealthcare.com email address. They asked, is it true that polyethylene glycol, or PEG 3350, needs to be separated from other meds? And if so, by how long?
That is an interesting question.
Mhm.
So, we know that intestinal transit time, so how fast an oral medication travels through the gut, can theoretically affect its absorption.
Right. And the thought is that the faster a med moves through, the less time it has to be absorbed. And that could lead to low blood levels.
So, when I looked into this, Don, there are a handful of studies, but not many, that
Mm.
looked at laxatives and drug absorption. And of those, very, very few looked at PEG. One example I found is a 1999 study that showed daily PEG decreased digoxin absorption
Mm.
by up to 40%.
Okay. So it could have effect on absorption then.
Yes, but what is interesting here is that none of the patients in that study saw any clinical effects despite those changes. And it's hard to really apply this study. The patients were healthy volunteers given a single digoxin dose. They weren't on chronic digoxin therapy for an actual heart condition.
Okay. So absorption can change, but that doesn't mean we'll always see changes in the actual effects. But I could see how this would be important for meds with very narrow dosing windows, where small changes can have big effects, which we call the narrow therapeutic index or NTI. But not all meds are that finicky.
I agree. Not all meds are alike. And in fact, a 2025 study of using PEG with dabigatran, an anticoagulant,
Mm.
found no changes in absorption or blood levels with co administration. Still, some experts recommend prioritizing spacing any laxatives at least 30 minutes from specific meds, things like diuretics, corticosteroids,
Mm.
and antiarrhythmics to just avoid this absorption issue, even if it is theoretical.
Right. So it's not as cut and dry here. It may be ideal to separate PEG from certain medications, especially if they have a narrow therapeutic index or if the patient is taking multiple laxatives. I could see how this could be cumbersome for patients and affect adherence, which may not be worth it if clinical effects are rare. An easy approach may be to recommend patients take their PEG dose at lunch, since most meds are taken in the morning or before bedtime.
Yeah, that is a creative option. And something worth
Mm.
saying here is that laxatives are intended to get patients back to normal intestinal transit time, which most meds are designed for, right? So, my concerns for absorption issues would probably increase if PEG was giving a patient diarrhea, or if the patient was cycling on and off PEG, making absorption of chronic meds erratic, right?
Yeah. Yeah. And adjusting the laxative regimen to the lowest doses needed and monitoring the patient for clinical changes are good steps to take in that case.
And we're just talking about PEG here, folks. Other
Mm.
laxatives have other interactions, such as magnesium-based laxatives binding to quinolone antibiotics, such as levofloxacin. So explore our management of constipation chart for details on common interactions to watch for, along with dosing, warnings, and more.
Yeah, that is a great resource. And I'm glad we could squeeze out the facts on that question, Steve. And thanks for listening to this bonus mailbag. Keep sending questions through the link in the show notes or email.
And we'll be back with our next full episode on opioids coming soon on August 18th, where we'll see which claims hold up and which ones are just a pain. And we'll see you then.